The second half of this oncology paper presentation will be chaired by Dr. Eugene Regala, the training officer of the section of Medical Oncology, UST Hospital and Medical Center. Dr. Regala is an assistant professor at the UST Faculty of Medicine and Surgery and a consultant at the hospital that bears the same name where he also finished his training. He is a fellow of the Philippine Society of Medical Oncology, the Philippine College of Physicians, and a member of several international oncology societies: the American Society of Clinical Oncology, the European Society of Medical Oncology, and the International Association for the Study of Lung Cancer. His research interests focus on clinical trials for head and neck, lung, and breast cancer. May we call on Dr. Eugene Regala to chair the rest of the oncology paper presentations.
Good evening. I'm Dr. Regala, and welcome to the continuation of the oral paper presentations. Our fourth speaker will talk about the accuracy of pleural fluid CRP in differentiating between tuberculosis and malignant pleural effusion. May I call on Dr. Ericson King from the University of the Philippines, Manila, to present his paper. For our second to the last speaker, who will be presenting their paper on MiroRNA-214 expression and its prognostic importance in non-small cell lung cancer patients, may I call on one of the researchers to present their paper: Min Liu, Hu Chong, Fang Liu, Tao Ho, Yan He, Chun Hong Hu, and Ping Liu. As we conclude tonight's oral paper presentation, I would like to call on Dr. Rita Gilmanova, who will present her paper entitled "The Possibilities of the Use of Raman-Spectroscopy in the Diagnostics of In-Vitro Urinary Bladder Cancer." Everyone, let us welcome Dr. Rita Gilmanova.
When dealing with pleural effusions, distinguishing between tuberculous and malignant etiologies is often a tricky puzzle. Both would present with an exudative type of effusion, and both would have lymphocytic predominance on differential count. Cytology can help in detecting cancer, but its sensitivity is only around 40%, whereas AFP smear and culture are also not reliable in diagnosing tuberculous effusions because it's actually a result of a delayed hypersensitivity reaction. There are other tests with better accuracy in diagnosing TB, such as adenosine deaminase and interferon gamma, but these are only available in few specialized centers. C-reactive protein is an acute phase reactant that is markedly elevated in inflammatory conditions such as infection. In pleural fluid, CRP has been shown by numerous studies to be significantly higher in tuberculous compared to malignant effusions, suggesting its possible utility in differentiating between the two. However, the studies available were small and used different diagnostic cutoffs. In this meta-analysis, we determined the accuracy of pleural CRP in differentiating between malignant and tuberculous effusions. We also generated a summary receiver operating characteristic curve to identify the optimal cutoff value that would have the best sensitivity and specificity for this purpose. Studies were identified through a literature search of databases and snowballing. We excluded studies where insensitivity and specificity data was not reported or could not be calculated. The quality of the individual studies was evaluated using the QUADAS assessment tool. We found 9 relevant studies, all of moderate to good methodological quality, and providing a total of 783 patients. The standard test used for confirming the diagnosis of TB or malignant effusions across the different studies are presented here, as well as the different cutoff values used in their analysis. We used the DiagMeta package by Steinhauser and colleagues to combine information on the diagnostic performance of pleural CRP at the different cutoff values reported. Across the 9 studies, 19 data points were generated. Model selection was based on which one had the lowest restricted maximum likelihood value, and in this analysis, it was the common intercept difference slope model. We then used the model to calculate the optimal cutoff and estimate the diagnostic accuracy of that cutoff. The calculated optimal cutoff for the SROC curve was 21.9 milligrams per liter. Pleural fluid with a CRP value higher than this cutoff is classified as from tuberculosis, while a lower CRP value is consistent with malignancy. This cutoff had a sensitivity of 91%, specificity of 82%, and an AUC of 0.91. Sensitivity improves to 95% at the cost of lower specificity at the cutoff of 20 milligrams per liter, while specificity improves to 94% at the cost of lower sensitivity at the cutoff of 30 milligrams per liter. The computed likelihood ratios are as indicated, and shown here for comparison is the performance of other established tests based on published data. We also performed sensitivity analysis by applying the other model specifications and comparing it with our selected model. We found that results were robust to the type of model used. These results show that at the optimal cutoff of 21.9 milligrams per liter, pleural CRP has good sensitivity and specificity in distinguishing tuberculous from malignant effusions. In a more practical perspective, a value less than 20 milligrams per liter is supportive of a malignant etiology, while a value greater than 30 strongly suggests tuberculosis. In the continuum between 20 to 30 milligrams per liter, the probability of tuberculosis rises as CRP increases. Adenosine deaminase remains to be the superior test for diagnosing TB and should be preferred if this is available. Cytology and pleural biopsy remain as the standard for diagnosing malignant pleural effusions. Nevertheless, an AUC of 0.91 indicates that pleural CRP can be a useful adjunct in the diagnostic approach to exudative lymphocytic effusion. So, what is the potential clinical utility of pleural CRP? We know that up to 60% of patients with malignant pleural effusions will have a negative cytology. Not all patients will have a demonstrable lesion that will guide a targeted biopsy, and not all patients will consent to this invasive procedure. Also, not everyone will have access to ADA testing, especially in non-specialized centers and low-resource settings. In contrast, testing for pleural CRP is widely available using the same assay we use as for serum, and is significantly cheaper at around $1 compared to ADA, which costs around $100. So, in a patient already diagnosed with a malignancy, a low pleural CRP can be used as supporting evidence for a malignant cause of effusion, especially in cases wherein cytology is non-diagnostic and more invasive procedures are not feasible or are refused by the patient. In a patient not known to have cancer, a low pleural CRP value can signal the clinician to have a higher index of suspicion for malignancy, and as a result, be more aggressive in searching for a lesion and potentially avoid delays in diagnosis. One factor that has to be taken into consideration when interpreting these results is that the included studies analyzed patients deemed to have an exudative type of pleural effusion based on Light's criteria. It should be remembered that up to a third of pleural effusions that are exudative by Light's criteria are actually transudative in nature. This can be confirmed by taking the albumin gradient between the patient's serum and pleural effusion with values greater than 3.1 grams per deciliter consistent with a transudative cause. So it is very important to rule out misclassified transudative effusion before considering a malignancy in this scenario. To our knowledge, this is the first meta-analysis that summarizes the accuracy of pleural CRP in distinguishing between tuberculous and malignant effusions. Our findings suggest that pleural CRP can be a useful adjunct to the current diagnostic strategy in differentiating between tuberculous and malignant etiologies, especially in high-burden countries. Thank you and good day.
Ladies and gentlemen, good afternoon. I'm very glad to have this opportunity to attend the conference. First of all, I want to introduce myself. My name is Lu Ming, a member of the team of Professor Liu Ping. I come from the second Shanghai Hospital, Central South University, China. The topic I'm asked to speak on is abnormal microRNA-214 and drug expression and its prognostic importance in non-small cell lung cancer patients. My presentation will include these four parts. First, the background of our research. Second, the materials and methods we have proposed in the paper. Third, I will introduce the experiments results, and the last, some conclusions we have got. Firstly, I would like to introduce the background of our research. As we know, lung cancer is the most important reason for cancer-associated mortality worldwide. MicroRNAs can target the untranslated region of corresponding sequence and mediate to down-regulation of target mRNA to control protein. The function aspect of microRNAs is well known in tumor growth, differentiation, migration, and conversion to other organs. The expression differs of microRNAs in different body fluids, such as serum, plasma, were found to be associated as important diagnostic or prognostic indicator for disease. Several evidence revealed that microRNA-214 regulation can be contributory factor for many tumors. MicroRNA-214 has been associated to be important circulating microRNA, and its expression in serum have shown to be diagnostic importance. Also, to examine the serum-based abnormal microRNA-214 as prognostic marker, to find and ask clinical significance as molecular marker in non-small cell lung cancer. We conducted this study to identify potential role in non-small cell lung cancer patients. Secondly, I would like to introduce the materials and the methods in our paper. 100 non-small cell lung cancer cases and 100 health centers were curated to examine the pleural microRNA-214 expression. Patients' blood samples were collected to separate the serum for exosomal isolation. Totally extracted RNA were used to make the cDNA, which was used to confirm the microRNA-214 expression. For demographic and clinical features of non-small cell lung cancer patients and healthy countries were depicted in Table 1. 63% of the patients were over 15 years old. Males were 71% and females were 29%. 83% patients were in advanced stage, while 15% patients had extended organ metastasis. Adenoma carcinoma patients were 42% and 58% were squamous cell carcinoma. Okay, now we move to the results of the experiment. In Table 2, we can see overall more than 17-fold increase expression was observed in serum-based abnormal microRNA-214. Non-small cell lung cancer patients in early stage showed more than 14-fold increased serum-based abnormal microRNA-214 expression, while advanced stage patients had more than 18-fold. And the differences was found to be significant. Patients who have distant organ metastasis, such as adrenal gland, lymph node, and so on, had a 19-fold, while no distant organ metastasis showed 15-fold. It has been observed the non-small cell lung cancer patients who showed pleural effusion showed 19-fold, while those who did not have any pleural effusion showed 17-fold increased serum-based abnormal microRNA-214 expression, and differences was found to be significant. Otherwise, we found that no such association was observed in the serum-based abnormal microRNA-214 expression with any smoking parameters. However, patients who smoked pipe and cigarette together had increased microRNA-214 expression. Cigarette and pipe smoker had more than 17 and 16-fold increased serum-based abnormal microRNA-214 expression, while pipe and cigarette smokers together had more than 21-fold increased cell-based exosomal MiroRNA-214 increased expression. To calculate the importance of cell-based exosomal MiroRNA-214 as prognostic or predictive molecular marker for non-small cell lung cancer patients. Simultaneous parameters such as PNM stage, distant order metastasis, and lymph node involvement were divided into two groups, and ROC groups were plotted. Higher AUC was observed for early or advanced TNM patients. Present distant organ metastasis and pleural effusion suggested that would be used for prognostic indicator. In this result, we can see patients with less than or equal to 14-fold MiroRNA-214 expression showed 21.2 months of median OS time, while greater than 17-fold expression showed 15.4 months of median OS time. It was observed that patients in early stage, like 1 and 2, had low median OS time being constructed to advanced stage patients. It's only 23.6 months. Now we come to the last part, conclusion. Patients with more than 17-fold increased MiroRNA-214 expression could be used as an indicator for poor non-small cell lung cancer patients' survival. Starting tolerated higher cell-based MiroRNA-214 expression is associated with advancement of disease, and it suggested that cell-based MiroRNA-214 expression could be used as prognostic and pulsify indicator in non-small cell lung cancer patients. That's all for my presentation. If you have any questions, please feel free to contact me. Best wishes for everybody. Thank you.
Good afternoon, dear colleagues. My name is Rita. I am an oncologist, and today at the conference I represent the Bashkir State Medical University, Russian Federation. Your attention will be presented a report on the topic clinically and investigative applications of Raman-Spectroscopy in the diagnosis of bladder cancer. Bladder cancer is the most common malignant tumor of the urinary tract, and in terms of prevalence takes 7th place in the structure of oncology in men and 17th in women. In Russia, bladder cancer takes 9th place among men and 16th among women. Bladder cancer is more common in men than in women, 3-to-1 ratio, which is associated with a higher prevalence of smoking and professions associated with carcinogens among men, which increase the risk of developing the disease. On this slide, we see an increase in the number of cases of bladder cancer by 2014. The number of cases will be more than 800,000 people. Accordingly, mortality from this pathology will increase. On the 13th May 2017, the 17th World Health Assembly adopted a draft resolution on cancer prevention and control. During its deliberations, there was broad consensus that cancer is a growing public health concern which requires increased attention and funding. Russia adopted a national project, the Federal Project, Fighting Oncological Disease for 2018-2024. According to the classification of the World Health Organization, bladder cancer refers to malignant epithelial tumors. The most common of which is urothelial carcinoma, accounting for up to 19% for all tumors. Urothelial carcinoma is clinically anatomically divided into two groups: muscle non-invasive, TEs, TA, and T1, and muscle invasive group, T2, T3, and T4. Patients with muscle invasive form require more aggressive treatment and follow-up. Early diagnosis of bladder cancer, evaluation of muscle invasion is important for the timely, effective, and successful treatment of this pathology. The gold standard for verifying a diagnosis is a pathomorphological study. But the problems of scientific support for the creation of new high-precision and effective methods for the early diagnosis of bladder tumors present an urgent problem in modern oncopathology. In Raman-Spectroscopy, sample is illuminated with a monochromatic laser beam, which interacts with the molecule of sample and originated a scattering light. The scattering light having a frequency different from that of incidence light is used to construct a Raman spectrum. Raman spectra arise due to inelastic collision between incidence monochromatic radiation and molecular of samples. When a monochromatic radiation strikes at samples, its scattering into directions after its interaction with sample molecules. Much of this scattering radiation has a frequencies with equivalent frequencies of incidence radiation and constituents relaying scattering. Only a small fraction of scattering radiation has a frequency different from frequency incident radiation and constituents Raman scattering. Raman spectroscopy contains several advantages over other diagnostic methods. Easy sample preparation, a large amount of information received, non-destructive nature of the analysis. The method allows of obtain both quantitative and qualitative information about the sample. Also, speaking about the advantage of Raman spectroscopy, it is worth noting the high analysis speed and the ability to conduct research without direct physical contact with biological agents, which was reflected in the identifications of pathogenic viruses inside infected cells. In addition, there are two molecules that have the same Raman spectra, and the intensity of the scattering light is related to the amount of matter. Experience of our center. We studied the material obtained from 75 patients with a histological confirmed diagnosis of bladder cancer who were treated in our department, in our clinic, and 23 samples of conditionally normal bladder tissue. Next, tissue samples of bladder cancer were grouped by the fact of histologically confirmed invasion of muscle-invasive and muscle non-invasive cancer, tumor tissue of the bladder that were removed during surgery, or the transurethral resection of the bladder, and radical cystectomy. Tissue samples without sample preparation. The study of the samples was carried out on Horiba scientific configuration options on the slides. The Raman fluorescence spectrum of bladder cancer samples contain expressed peaks in the range of 500 to 1500, high peaks of 582, 715, 1000, 1100, which are absent in the spectra of samples of normal tissue. There is a significant increase in peak intensities in the regions of 850 and 1250 in the spectra of bladder cancer, as well as the appearance of a group peaks of low intensities in the region of 2,800 3,000. As for muscle-invasive and muscle-non-invasive bladder cancer, comparison of obtained data show that the intensity of the peak in tissue samples with muscle-invasive bladder cancer is significantly higher than in samples with muscle non-invasive bladder cancer. In this case, a particular striking difference is observed in the region of the 1,000, 1250, 60. The method of Raman spectroscopy showed reliable result in detecting bladder cancer, establishing the fact of muscle invasion, which can help in the timely diagnosis and proper treatment of patient with bladder cancer. I would like to say a few words about our center. Our center is a university clinic. We have students from Russia, Turkey, China, India, and others. Our university, headed by the rector, Professor Valentin Pavlov, actively participated in international conference in the university clinic's surgical interventions of verified complexity, laparoscopic, robotic operations are carried out. This year, a biobank was opened on the base in our university. There is also a cell technology center. We will be happy to cooperate with other universities for the benefit of the development of science, for the benefit of treatment patients. Take care yourself. Coronavirus has introduced the change in the organization of conference. Thank you for attention.
Okay, good evening, everyone. I'd like to introduce myself. I am Dr. Grace Nilo. I hope everyone can hear me. I am a medical oncologist from Manila, Philippines. And in behalf of Dr. Eugene Regala, I'd like to moderate this Q&A session for the paper presentation set 2. We heard 3 good papers from 3 equally good speakers. I'd like to acknowledge the other 2 speakers who are unfortunately not able to join us for the Q&A. We heard the paper presented by Dr. Lu Min on exosomal MiroRNA-214 expression in non-small cell lung cancer. And she talked about the prognostic significance of increase in the microRNA, which could mean poorer survival for non-small cell lung cancer patients. And we also heard the presentation of Dr. Rita Gilmanova from Russia. She talked about the possibilities of using Raman-Spectroscopy in the diagnosis of in vitro urinary bladder cancer. Unfortunately, they are not here to join us, but we have here the first speaker who is from the Philippines. We have Dr. Rich King, who presented a paper on the accuracy of pleural fluid CRP in differentiating tuberculous from malignant pleural effusion. So welcome, Dr. King. You can hear me, right? Okay. So we're monitoring the chat box. We still do not have questions, I think, but the team will inform us if there will be questions from the audience. So for those who would like to ask questions, just type them in so Dr. King can answer them. But maybe you would like to, since the whole floor is yours and we have 8 minutes for this, we'd just like you to elaborate further on the paper, on the use of pleural CRP, right? Um, how fast exactly can you get the results? For example, if you request for the test.
So since the testing for pleural CRP would use the same machine as we would use for the standard
Yeah.
serum CRP, then it would just have the same turnaround time. So that would be, I would estimate around 4 hours. And this would, I think, be similar to adenosine deaminase.
Mm. So pretty quick, right? You can get the results right away, which is what you want, right?
Yes.
Okay. Well, considering the you mentioned the cost, right? It's quite affordable. You mentioned something like one US dollar, if I remember it right. And considering the ease of or accessibility to the test, meaning it's quite accessible from what I understand, right? It's readily available. So would you foresee the test being used eventually, as a standard of care, as part of the usual panel that we request for pleural fluid cytology studies?
Since we saw that adenosine deaminase still has a better performance compared to pleural fluid CRP. I think the greatest utility this test would have would be in areas wherein ADA is not available or not accessible, or if it is, since it is cheaper, so it would be a cheaper alternative as well.
Okay, so it could be a good alternative to ADA. Um, how about where do you think would be the best use, or where could it be of more value in determining the pleural fluid CRP? Would it be during baseline, purely during baseline during treatment, or would it be even after the treatment, or where exactly in the treatment course do you see it giving it the most value to both doctor
For
and patient?
me, I think the best utility would be in the initial presentation of the pleural effusion, because that would already give us a better idea if we are going to lean towards a malignancy or lean towards a tuberculous etiology, and this would drive the workup. So would
Mm.
we do a more thorough CT scan, or we will be pursue a TB PCR for the patient?
So it's more of diagnostic. Okay.
Yes, ma'am.
Yeah. Okay. And lastly, do you think this should be done routinely among countries with high incidence of tuberculosis, like ours, for example?
I would not, I would not say routinely, but I would say if the more accurate tests are not available, or if the patient would refuse biopsy, then we can definitely consider pleural CRP. But of course, if the patient would consider for a VATS procedure, or if the patient can afford and can send out an adenosine deaminase test, then those are still preferred. But in many far-flung areas in the Philippines and perhaps also in other countries, these are not the case.
Okay. Okay, thank you. So I don't see any questions from the audience. So at this point, we would like to congratulate all the presenters for the good papers. Not only these three, but in fact uh, all those who submitted papers. We saw the papers; they were really good. So congratulations to everyone, and congratulations, Dr. King, for
Thank
this good
you.
paper on pleural fluid CRP. So
Thank
if
you.
there are no questions from the audience, we would like to end this short Q&A. And we would like to invite everyone to join us for the Battle of the Molecules. Good evening, everyone, and thank you.